I've never taught my students anything. I just try to put them in the best conditions to learn. Albert Einstein. Diapath is a leading company offering a complete range of innovative instruments, reagents and consumables for anatomic pathology. Diapath is based in Italy, near Milan, with a network all over the world. As you know, Diapath is approved CE use provider by NSH, National Society for Histotechnology. If you're interested in gaining CE use by NSH, you're welcome. You're invited to follow the instructions under the website www.diapath.com/webinars-list. Before starting the webinar, just a few practical information. The webinar is about 30 minutes. Then we are going to have a question and answer session at the very end of the webinar. So you are kindly invited to have your questions at the very end, typing the questions in the chat for the final open discussion.
Hello everybody, welcome to this webinar. So I will briefly introduce myself. So my name is Jeyrroy Gabriel. I want to first start off by thanking Diapath for giving me this opportunity to share with you a little bit about some research and innovation we do in our lab. So currently I work as a senior biomedical scientist in St John's Dermatopathology Laboratory at St Thomas's Hospital in London, which is a specialised histology lab which deals with an array of cutaneous disorders ranging from malignancies to autoimmune. So a common problem we encounter in the lab is how to deal with very heavily pigmented lesions. This can be quite problematic because the melanin can obscure the microscopic interpretation of the tissue sections. As well as that, it can mask antigen-antibody binding site, which can impact immunohistochemical staining. So in the lab, we developed a semi-automated method for melanin bleaching to help alleviate these problems. So that's what I'm going to run with you today. So in the title of a lecture of research and innovation in dermatopathology, development of an semi-automated melanin bleaching protocol. So before I go into the topic, I wanted to briefly look into why I feel, and in our department we feel, research and development is very important. So research and development helps foster new ideas for tests, products and services. As well as that, it allows for better and quicker diagnostic tools, which ensures better tailored treatments for patients. As well as that, it ensures techniques improve with the availability of new technologies. All of these factors are quite important because between 60 to 70% of medical decisions are based on in vitro diagnostic test results. And this figure is actually even higher in cancer diagnosis. As a result, it's very important to continually improve and develop your techniques. However, not just that, we also find that getting staff involved with research and development, it helps to give us a great sense of job satisfaction. As well as that, it enhances skills such as organizational, communication and teamwork skills, as well as expand scientific knowledge. All attributes which are vital in working in any diagnostic lab setting. So next, I wanted to briefly run through an introduction to melanoma. So melanoma is the 5th most commonly diagnosed cancer in the United Kingdom. However, on a global scale, it's roughly around the 19th most common cancer diagnosed in men and women. And this equates to about 300 cases diagnosed globally each year. Melanoma tends to have a higher prevalence in the Caucasian population, and risk factors include those with certain genetic mutations, such as patients with xeroderma pigmentosum, those patients who have a lighter complexion, and certain individuals who may have auburn or blonde colored hair or have increased freckles, or those who tan poorly or burn easily. So melanoma is actually the acquisition of a mutation in cells referred to as melanocytes, which can be found in the skin or even in pigment-producing cells of the eyes. Some examples of this include superficial spreading melanoma, nodular melanoma, acral antigenic melanoma, and lentigo malignant melanoma. What happens in melanoma? So in melanoma, as I described in the previous slides, the cells of the skin responsible for producing pigment called melanocytes acquire a mutation. And this results in usually uncontrolled cellular growth, proliferation, and all of that can lead to excess melanin pigment deposition, as you can see in these images on your left-hand side. And this can prove quite challenging, and some of you may have faced the same problem in your labs. So heavily pigmented lesions can be very problematic. This is because the melanin can obscure the microscopic evaluation, which makes it difficult to distinguish atypia from benign proliferation. As well as that, it masks antigen-antibody binding sites, which are key for any immunohistochemical testing you want to perform. As well as that, commonly used chromogens in IHC, such as DAB, have a similar brown color to melanin, which makes it difficult to distinguish genuine positivity from melanin itself. As well as that, alternative chromogens such as fast red and alkaline phosphatase, when mixed with the melanin, produce the brick red appearance, which you can see on the examples on your left-hand side. And you can see that it's very difficult to sort of interpret and distinguish genuine positivity and to the melanin itself. So I want to show you an example of why removing this melanin is vital to make a diagnosis. So here is an example of a lesion that we received in the lab. So you can see from here that there's extensive melanin pigment deposition in the lesion. So one could assume that this must be something sinister or a malignant disorder. However, after we bleached the section and performed a H&E, what we found was there wasn't actually a lot of melanocytes present in the cell, but they had a lot of cells which had a foamy appearance in the bleached H&E section. And when we ran some immunomarkers, as you can see from the HMD45, there was only thin strands of melanocytes in the cells, and vast majority of them were actually CD68 positive macrophages or melanophages. So in this particular case, what has happened is the macrophages has attacked these abnormal cells and pretty much destroyed it. And as a result, it's actually not classified as melanoma, but in fact classified as dysplastic nevus. And why is this important? This is important because the diagnosis will determine what treatment the patient undergoes. So if it was from an very unclear H&E, like at the top left-hand corner, it was incorrectly diagnosed melanoma, the patient may have to undergo wide local excision and central lymph node biopsies, etc., which are very invasive. So the diagnosis of dysplastic nevus and melanoma can make a big difference to the patient's treatment and outcome. So as a result, it's always important to have a clear histological picture before making any diagnostic decisions. And without removing the melanin, that would be quite difficult. So next, I wanted to mention the fact that this is not only just for cutaneous disorders. This is also encountered, as I mentioned previously, in melanoma of the eye, such as uveal melanoma or choroidal melanoma, as well as in metastatic disease. So you can have examples of metastatic melanoma in the duodenum, which you can see in the bottom left-hand corner, and a fine needle aspirate sample of metastatic melanoma in the cytology specimen. So currently, there are two main bleaching methods that are utilized routinely. First of which is use of potassium permanganate. So this is the faster of the two methods. However, it can cause an issue of over-oxidation. and this can damage the antigenic sites, which are vital for performing immunohistochemical testing. So as a result, it's mainly just used for H&E staining. The second method is the use of dilute hydrogen peroxide. This normally takes a lot longer, and it can take up to 24 hours. But in our lab, Dr. Guy Orchard had developed a method utilizing heat to bring this temperature down to 1 to 2 hours. And as well as that, it does not have the same adverse effect on antigenic sites, so it's safer to use on IHC stained slides. So, however, it's important to highlight both of these methods are performed manually. So, the rationale, why did we do this research project? So the rationale why we wanted to develop a or an automated melanin bleaching method was the main reasons involved the fact that with any sort of manual method, it's very hard to standardize. And we live in an era where majority of labs across the globe are trying to adhere to very good standards of ISO laboratory standards. So we wanted to make it an automated method which is a lot more easy to standardize. Not just that, by automating it, it will free up staff time for staff to be able to do other things. And in a busy diagnostic lab where you're constantly bombarded with specimens and samples you want to deal with, you want to make sure you work in a very efficient manner. And so by making automated, you can focus on other things while the machine does most of the work. So we try to utilize an existing IHC platform to be able to perform this bleaching step in an automated manner. So to do that, what we did was we analyzed and identified 24 cases of very heavily pigmented lesions, which equated to about 29 histological blocks in total. So each block, paraffin block, we cut cut and stained one H&E which was unbleached. One section slide we bleached first on the automated platform and then staged for H&E. And the next set of slides we cut were first bleached on the machine on the protocol we devised, and then we ran some immunomarkers straight afterwards, melanoma markers such as S100, melanin, SOX10, HB45, and SCD68 as well. So in total, this equated to about 203 slides that we assessed. This may look like there's a lot of information, but I'll try and summarize it to the best of my knowledge as well. So this is actually the protocols that we were able to optimize. So this protocol can be adapted to a variety of different automated platforms, but to be able to do that, there's only certain key things that we followed that will allow you to adapt it to other platforms. So because we were using formalin fixed paraffin embedded blocks, we selected the deparaffinization step first to remove the wax. And the next what we did was we utilized a primary antibody step to actually apply the bleaching solution, and that's why this was a semi-automated rather than fully automated. So to do that, we made up 10% dilute hydrogen peroxide in phosphate buffered saline, and then we applied it onto the slide via titration and incubated it for 1 hour. And so this protocol can be adapted to a variety of different IC automated machines that are available on the market. Once the slides were all bleached and stained, we did a microscopic interpretation of these slides. So to evaluate the H&E slide, what we first did is looked under the microscope to make sure that the bleaching was effective in removing the color from the melanin pigment. Then we looked at the general morphology to make sure that the tissue integrity was maintained. We then looked at whether there was any sort of artifacts of oxidization, which includes sort of lifting, folding, poor cellular morphology, as over-oxidation can lead to that. And finally, we looked at the actual quality of the H&E staining, the hemotoxin usage staining, whether it was good quality or poor quality. So for the immunohistochemical stain slides, we again looked at whether the bleaching was effective in removing the color from the melanin pigment. Again, we looked at to make sure that the antigenic localization was correct, so we were seeing correct cytoplasmic and membranous or nuclear staining. And we also looked to see if there was any artifacts such as overstaining or background staining, and ensure there's correct intensity of staining as well, which are all important characteristics that we were looking for. So in the results, we actually found that all the cases actually showed successful bleaching of melanin. The tissue morphology integrity was preserved in most of the cases, apart from 2, which shows partial detachment, predominantly in the dermal region. However, all the bleached H&E did show vastly improved morphological clarity compared to the unbleached sections. And the results for the IHC stain slides were easily interpreted, giving excellent morphological detail and the ability to determine antigenic localization. So next I wanted to go through some examples of cases that we ran as a part of the study. So here you can see an example of a superficial spreading melanoma. So if we have a look at the H&E at the top left-hand corner, you can see very extensive melanin depositions within the sections. And as you can imagine, this can make it quite difficult for the pathologist to microscopically interpret the slides, because the cellular morphology is completely obscured. You can barely see the nucleus. And it'd be very hard for them to make a definitive diagnosis. However, if you look at the bleached H&E in the bottom left-hand corner, you can see that the melanin pigment has been completely removed. Each of the individual cells are very easily visible. The nucleus, you can in fact see the larger hyperchromatic nucleus even from this image here, and even you can see the finer details such as the nuclear mitotic figures as well. These are all things that will make the pathologist's diagnostic process a lot easier. As well as that, if we look at the immunomarkers, we see here that all of them shows complete melanin pigment color removal, and they show they also, as well as that, the antigenic localization is also very easily visible. So you have S1 under showing clear nuclear cytoplasmic staining, and then SOX stain showing clear nuclear staining. So all of these would help make it very easy for the pathologist to make a diagnosis. There's no melanin obscuring the positive staining, so it's an important factor that it needs to be done, the bleaching, to ensure that the slides can be easily read and interpreted. So next we have another example of a nodular melanoma, which again shows unbleached sections show at the top left-hand corner here, with extensive melanin deposition throughout the tissue, as well as in the lower left-hand corner again, you can see from the H&E that the melanin has completely been removed by performing the melanin bleaching process in a semi-automated manner. Then again, we have the immunomarkers, which again are quite clear and there's distinct staining with no residual melanin pigment present in the section, which again will assist the consultant to make a very accurate diagnosis. In conclusion, what did we find? So we found that a classification of melanocytic lesion is often difficult diagnostically because the melanin, as we said, impedes the microscopic interpretation. Commonly used chromogens in IHC, such as DAB and fast red, can be quite difficult to distinguish from the melanin itself, and as well as that, it does not address the masking effect of melanin on the antigen-antibody binding sites. Up until recently, as I mentioned earlier, the melanin bleaching protocol has been done through a manual method, predominantly through this dilute potassium hydroxide method. However, here we were able to describe a protocol and generate a protocol that allowed us to bleach the section on an automated immunohistochemical platform in a semi-automated manner. and we were actually able to achieve successful bleaching and staining of heavily pigmented lesion within 5 to 6 hours using the fast red in combination with alkaline phosphatase, which is quicker than if we were to do the manual bleaching, which would normally take around 6 to 7. This time could actually be made even quicker if we were to use the DOB kit, which we didn't use in this instance because, as I mentioned earlier, we didn't want there to be any sort of doubt in interpreting the melanin from the actual chromogen. So, but you would probably be able to achieve bleaching and staining within 3.5 hours, which is quicker than if we were to do the bleaching manually, which all in total will probably add up to about 5 hours, depending obviously on the antibody protocol, incubation time, etc. So I wanted to finally end by acknowledging my co-authors of this publication. So Dr. Guy Orchard, who is actually the lead author for this paper, is actually the individual that first developed the manual method and came up with the idea of actually let's try this on the automated method as well in our lab, and we were able to successfully achieve this to the protocol I mentioned earlier. As well as with the help of my colleagues, senior colleagues here, we have Patricia Fernando, Fiona Ishmael, Mohammed Shams, Thaddeus Nowaki, Jose Satov Jr., and Christina Diamico, who was actually one of our very beloved colleagues, who has now has a flourishing career in Diapath, which we are extremely proud of as well. So yeah, I want to thank my colleagues for this and for giving me the opportunity. I also wanted to finally say that if you want to find out more about this, what the method we developed and optimized, you can find this in the British Journal of Biomedical Science, and it sets out exactly what we did and how we went about and did it, if you want to learn a little bit more. And I want to, and these are some of the references if you would like to review any of those. And I would finally like to say a big thank you again for joining us today, and I want to thank again Diapath for giving me this opportunity to share with you what we've done in the lab. I hope you enjoy your rest of your day.